1 in 3 women will die of heart disease. It is a leading cause of death in Europe and around the world. Yet it is medicine's most silent killer. Most of us won't recognize the symptoms or all of the symptoms of a heart attack when it hits women. Welcome to the Women's Health Uncovered podcast. I'm your host, Mariam Harutyunyan, and in this podcast, I sit together with researchers, doctors, policymakers, industry leaders to bring you conversations that matter, so you can learn more about women's health and how it impacts all of us. In this episode, we will put women's heart health in the spotlight. You will learn about the signs that are often overlooked in women, how symptoms can differ in men and women, and why these differences matter. We will explore the signs you should look out for, the questions you should ask yourself or your doctors, and which changes that are necessary in policy and care to make sure that women are not left behind. It's time to uncover the path to better women's health. And to do so, I invited 2 remarkable guests. Professor Dr. Bharati Shivalkar is a cardiologist and a leading voice in women's cardiovascular health. Her ambition is to address systemic disparities in care and help shape initiatives that close a gender gap, ensuring women's health stays at the forefront of healthcare innovation. Welcome.
Thank you. Pleasure to be here.
I have a quick question for you, Bharati. If you had to describe the knowledge gap about women and heart disease in one word, what would it be? Anything that comes to mind?
Outrageous.
Outrageous. Why did you choose that word?
Because women are almost more than 50% of the world's population.
Yes.
And there's a gender health gap, which is 25%. Women live longer than men, but up to 25% of their lives is in poor health compared to that of men.
Yes.
So in the 21st century, I find that an outrageous statistic.
Exactly, indeed. I follow you there. My second guest is Birgit, the CEO of the European Heart Network. With over 20 years of experience in EU health policy and law, she leads efforts to put cardiovascular health, and especially women's heart health, at the top of the political agenda. I have a quick question for you, Birgit. If you had to describe what's missing in European heart health policy in one word, what would it be?
Implementation.
Implementation, yeah. I can understand why, but why did you choose that word?
I wanted to say awareness, but it's not enough. We want implementation. So we want taking care of women's health, especially in cardiovascular health, and being it implemented policy measures to change it. So awareness is maybe the first step, but what we want to see in the end is implementation.
It's implementation, indeed. I mean, cardiovascular disease is often called a silent killer, and for women, that silence is even louder. 1 in 3 women, as I mentioned, will die from heart disease, yet many of us don't know the signs or don't realize how different those signs can look compared to men. Bharati, what is the biggest misconception people still have about heart disease in women?
Well, I'd say that there's this grounded notion at the societal level that heart disease is a man's disease, and that it primarily affects men. Now, that's the reason why there's been, as far as women's health is concerned, there's been the bikini medicine focus on women's health. Now, that concept, that notion is to some extent true. It's a matter of age, really. So if you look at heart attacks, for example, the incidence of heart attacks is twice as much in men compared to women before the age of 50.
Yeah.
Right? So, there's the protective effect of estrogens. Estrogens have a positive effect on the vascular health. So to some extent, women are protected from heart disease up to the age of, the middle age, 50. And this obviously also coincides with the occurrence of menopause, which is the average age around 50, 51 years when women go into menopause.
Yeah. When
the protective effect of estrogen falls away. But what we are missing there is the individual risk factors of women. So we have a lot of women at a lot younger ages who have women-specific and women-predominant risk factors, which are putting them at a much higher risk of having heart disease.
Yeah. What are things that women come to you for that, or well, when they come to you with heart symptoms, what's something she often doesn't know about her own body?
It depends really, what you're looking at. If it's heart attacks, then it's the symptomatology.
Yes.
Which is very different. When you talk about a heart infarction or a heart attack, the classic image that comes to one's mind is a middle-aged man, is the Hollywood-style scenario, the middle-aged man groping, grasping his chest with excruciating pain and dropping down to the floor, dropping down to the ground.
Yeah.
Now, women do have chest pains, but it is not to the same extent as that of men. Up to 50% of women who are suffering or who are experiencing a heart attack will have chest pain, but it may not be to the same extent.
So there are similar symptoms, but they're not either expressed in the same way, or there are also different symptoms.
There are also different symptoms.
Yes.
So, as I said, up to 50% chest pain complaints. There are also other symptoms such as dizziness, lightheadedness, shortness of breath, nausea, vomiting.
And these are specific to women?
These are much more common in women.
Okay, yeah.
Nausea, vomiting, jaw pain, neck pain, pain radiating to the back or the shoulders, and sometimes even just fatigue. And that's the reason why most healthcare professionals overlook them or misdiagnose it. And a lot of women are sent home, with the diagnosis of anxiety, of just indigestion.
Yeah, so misdiagnosing or just overlooking the symptoms, and that creates then that heart disease is the leading cause of death. I'm curious, Birgit, what do current EU mortality rates show us about cardiovascular disease in women?
Yeah, as Bharati said, it's perceived as a man's disease, but if you look at the figures, EU 27, it shows 37% of women die of cardiovascular disease and only 31% of men. So it is actually a women's disease, if you summarize it at that. And it also, if you look to different disease areas, cancer, CVD remains the killer number one in Europe and worldwide. So it is this awareness which we are trying to bring to the public, to the policymakers, to create change.
Mm-hmm. And the figures they don't lie, right? And on top of that, what we should be aware of is there's this huge geographic disparity across Europe. So 35-37% women on average, that's more than men, partly because women are living longer. That's you have that discrepancy. But if you look at the geographic disparities, some of the East European countries, you've got up to 58% cause of death as heart disease being as cause of death in women.
Yeah,
right?
yeah.
And so we are looking at countries like Bulgaria, Lithuania, and Romania. This is a shocking statistic.
Yeah. And are we making progress? Are these numbers changing?
Not yet. At the moment, we are struggling with the consequences of COVID. So many people have missed consultations in that time. And that backlog is currently the latest figures we have for 23 and 24. The figures are going up for CVD. So we have to recuperate COVID and we have to make shifts in the healthcare system that they are more resilient and catered to everybody.
And where are we seeing the biggest gaps to do that?
I think it's the access to healthcare already. So getting everybody early diagnosed, but it's also the step beforehand. It's prevention. We are still missing the implementation of prevention policies. So tobacco legislation, physical activities, healthy diet. These are risk factors which were still very dominant and which have a huge impact on cardiovascular disease. Also in women, we are talking more with women of an excess risk, so that their risk factors even are more propelled than for men due to biological factors.
Yeah, and even today, women are 50% more likely to be misdiagnosed after a heart attack. That's what you also mentioned, but many of us wouldn't recognize the symptoms, as we said, but it's not just a heart attack. Which cardiovascular conditions are often misdiagnosed or overlooked in women?
Well, it starts at a very young age, early age. So you've got certain women-specific diseases, actually, that are not diagnosed early enough. So here, and this happens at a much younger age. So we're talking about endometriosis, polycystic ovary syndrome. These are potential risk factors which are occurring at a very young age, potential risk factors for later cardiovascular disease, right? Then I'm also thinking about younger women, pregnancy-related complications, where you've got hypertensive pregnancies or gestational diabetes, which are precursors of cardiovascular risks and cardiovascular disease, and in a foreseeable time. So let's say within 10 years of a complicated pregnancy, you have those effects which become really obvious, cardiovascular effects which become obvious. I'm also thinking about younger women who have a family history of premature heart disease. These women are also at a very high risk of having coronary heart disease or hypertensive disease or hypercholesterolemia, for example, which all lead then to fulminant, full-blown cardiovascular disease. And so these are, women are not protected all the time. There is a certain percentage of the population who may not have their specific medical issues, the ones that we talked about, the women-specific and women-predominant. One women-predominant issue that I forgot to mention here is autoimmune diseases. So you have a very high percentage of patients that are women who present with autoimmune diseases such as rheumatoid arthritis, systemic lupus, Sjögren disease, thyroid issues. So we have a very high percentage of women presenting with those. And these are younger women who are, it's like a time bomb almost, I'd say.
Yet the WHO says that 80% of cardiovascular diseases is preventable. So where are we going wrong?
Well, we're just not taking sufficient care of ourselves. We live in a society that is primarily sedate. We don't move enough. High levels of processed foods. The intake is much higher than it had been, let's say, even 20, 30 years ago. This is not rocket science. 80% is preventable. That's a fact.
Yes.
And so we should be doing better for ourselves.
Yeah, but also I think it's the journey up to the screening and the prevention aspect of it. So where are we losing women in the healthcare pathway? You can go to your doctor and then you have to see a specialist. So where in there is the gap happening?
It's everywhere. I think that's the problem, and I think it starts with the awareness of the pathway system, that women are very busy, that they maybe have less access because it's lower income. The transport is maybe more complicated. They are taking care of family members, so they don't look so well after themselves because they're busy with their family and their kids. And then I think it's also the issue that there is a bias still towards women, that the pain is less recognized with women than in men. Symptoms are misdiagnosed. There's a lot of misdiagnosis. And even if women had a heart attack, for example, they receive less care. There's a higher risk to get a second heart attack just because the aftercare is not taken care of. So it happens actually throughout the whole pathway that women fall through the gender gap. And it's because the system is not aligned to it, and it goes further in other areas. It goes in clinical research, that clinical trials are done with middle-aged white men because they are available. So there is not the idea to look into women, into children, into older women, younger women. The whole spectrum is not adapted. And that means that neither the care, nor the diagnosis, nor the treatment is adapted to women's needs, because they're not researched, they're not taken aboard, they're not taken within the healthcare system in an adequate manner.
Is there something they can ask their doctors themselves? So questions they could be asking to make sure that either they have the right attention or, taking it in your own hands?
I think it's the awareness factor to know maybe the symptoms of what you could be presenting, and maybe in a dialogue saying, well, I have this symptom and that symptom, really describe also maybe the life situation that I'm having, that, for example, it's a very busy life, that I have to take a lot of stress, take care of the children, that the day-to-day life is cumbersome, they are facing this and this issues, and that they present maybe all the factors, but it's also needs on the opposite side. Doctors need to have the enough time and the awareness that these symptoms could actually be going into that diagnosis. So I think it's the whole system approach that women needs to have the awareness, the time to present the whole story, but doctors also need to have the time to listen and being aware also what they might be encountering. So I think it's a whole system approach which needs to be allowing for a shift.
Yeah. And Bharati, you mentioned some lifestyle factors. You're like, these are things that you could change or take into consideration to live a healthier life that will also make sure that you have a healthier heart health. What are some of the lifestyle factors you'd say you wish women would take into consideration? Like, what are the top 3 things that we are not doing and should be doing better?
Yeah. As I said before, we are sort of becoming more and more sedentary world, not just sedentary nation, sedentary world. So it is known that girls and women do a lot less exercise than men. And this is, I think, something, it should be made aware of at a younger age. So, we should be targeting schools regarding that. Healthy eating, they should be banning all these vending machines with chocolates and
the fast food
and all the sugar drinks and fizzy drinks and stuff like that. These are, as I said, it's not rocket science. These are simple things in life. What we did a lot more before. When I went to school in the UK, I did sports every day, an hour of sports every day. My son, who went to school in Belgium, he had, I think, 1 hour of sports per week.
A week, yeah.
And then what I heard from him is that a lot of the girls were, they had some excuse or maybe they had a valid reason for not doing the sports. But a lot of girls were just slipping through the system, as you were. They were not wanting to, not interested in doing the sports, even that measly 1 hour per week. And so I think, it's so important to create that awareness already at a young age. And also basically taking time for yourself, taking care of yourself. We live in such a stress-prone society that we are not perhaps relaxing enough, not taking, this is also part of looking after yourself.
Taking care of yourself and not forgetting that, in taking care of others, there is also your own body you have to take care of. And we perhaps became more, the busy lives that we call, or being behind our desk, behind our laptop, behind the phone, and less connection with the nature and physical activity, maybe.
And building up a little bit on what Birgit said earlier on, the COVID aspect, and also taking care of and, putting themselves, rating themselves as second in line to whatever's happening around. COVID showed that women are doing so much. So they're doing their jobs, they're taking care of the kids, they're doing the homework.
Yeah, it highlighted those factors.
Highlighted all those factors, and then the stress that women have, the extra stress that it creates in managing all those things, And then there's simply managing those things, taking care of them. There's simply no time left over to take care of themselves. This is one of the also one of the reasons why we have such a high morbid mortality in the East European countries, because men have some issues with work-related issues. There's a lot of problems of alcoholism, for example. Women work, they smoke. There's poor health hygiene as well, which has really caused that increase in that cardiovascular morbid mortality. And all those factors, smoking, not moving enough, stress, etc., causes also hypertensive disease, which is really a huge risk factor for women. The standard risk factors, cardiovascular risk factors, are the same in men and women, but they affect women differently to men. And so, the influence on the female body is much more. Hence, they suffer.
Yeah, that's why I think the prevention and the screening is quite important here. So I'm curious about what strategies the European Heart Network is advocating for when it comes to prevention and screening.
Well, what we're having an approach which actually says we try to put away the responsibility from the individual and saying it's just a lifestyle. What we are advocating for is to create healthier environments, which makes it easy to take a healthy choice because it's available, it's affordable, and it's close, as to say. So we are looking at measures on the legislative point of view, that we say we want labeling. So food should be labeled. What is unhealthy food, which is sugary, which is fat, which is very salty, so that this food is marked, but also looking into tobacco legislation, putting higher taxes, having also a proper labeling, front of pack labeling, advertising for tobacco, keeping children away also from vapes and from no tobacco products, no nicotine products, and then it's also the question transport. I mean, how do we can make people walk to work, work to school, integrate the physical activity and make it easy, a healthier environment. We're talking a lot about cities, that cities need to change to create a healthier life for everybody, and catching everybody has access to it. So that's a bit where we see prevention needs to come with a solid policy that makes it easier for the individual to choose, because it's not the unhealthy food in the vending machine, but there's healthy food in the vending machine. We actually had a project within EHN where our member from Lithuania and Italy worked together to talk to vending machines producers to change the food in there. And so that was it's just a very practical example.
Do you have another example? Because I find it interesting to hear how these strategies or policies are implemented. Implementation. We mentioned that in the beginning as well. Do you have any other examples how changing your environment?
A lot. Our members are very creative because they work at the local level, at the regional level. So they had one, for example, physical activities in women. They created a women's hurdle, so to jump hurdles. And they had it as a public action, and they visualized and showed women jumping the hurdles. That was a awareness raising campaign. Or another idea was to go into schools and to learn to feel your pulse, how to feel it. And then just as a simple measure for everybody, accessible without a watch, without anything, just to feel, is it regular, is it irregular, how does it go? So to create this awareness for the physical aspects as well, and for being in your body and with your body. So that is another practical example where or having video projects with schools, going against schools, and having a video with doctors and journalists and pupils, how a healthy lifestyle could look like, making little stories about it, so being playful about it. Educational.
I think that way it sticks if you make it some,
practical.
Exactly.
Playful.
Thing
that's, it must be attractive.
Doesn't it?
Yeah, exactly.
And teaching early on. You both mentioned school, so it's quite important that you know these things early on.
And there's a saying, educate a mother and save a generation. And it's just letting women understand. And that's where, these educational campaigns, etc., come in. Let them understand what their own risk factors are. because women will take heed, right? They are the medical
knowledge as well in the family, yeah.
Yes, and they are the economists. They are the manager. Yes, they're managing every aspect of the life, and so if you make them aware of certain problems that they may be facing, let's say 10 years down the road, they will pay heed. I'm sure of that. I have patients whom I talk to, and a young woman with pregnancy-related complications, and I told her of the problems that she could face if this would not be taken care of properly, and what she should do post-pregnancy, after the pregnancy. And she said she wasn't aware of that, and she knew several women who had been through the same issues who were not aware of those problems that they would face later on and what they could do immediately.
And what did she have to do? Or what was your advice?
Well, for a start, that she had to, obviously she was treated, and she was treated correctly during that pregnancy, but after the pregnancy, how important it was to take note of her blood pressure measurements, if need be, treatment, and indeed lifestyle measures. So she had to reduce her weight, because obviously a lot of women put on weight during the pregnancy, that you make sure that you get rid of that weight, because that's going to be an additive effect to getting to those structural heart problems that we see, and indeed the hypertension, and it can, in the worst case scenario, it can lead to young stroke. So a woman who's had, let's say, an hypertensive pregnancy between the age of 25 and 30, you could be looking at a stroke before the age of 50 in that woman. I've known such cases, this I'm talking from experience. So you need to explain to her the sort of lifestyle measures that she can undertake to make sure that she's not going to get to that stage.
What I'm also interested about is, how do we make sure that risk communities aren't left behind?
I think it's a general topic where we need to make sure that health measures, policy measures which are taken are addressing everybody, whether we are talking to migrants. Women are also a risk community in a way, because I mentioned they manage a lot, they have lower incomes, they grow older, but they live on their own when they're old. So they're taking care much later, because maybe they have a heart attack when they're on their own. Their symptoms are not recognized with colleagues, because they might represent a bit different than they're underestimated because of women and pain. Well, this is a stereotype, hysteric maybe. So I think the policy needs to have an proactive approach to fight health inequalities, because that's where it starts to create gaps and to not enable everybody to have access to healthcare system as everybody else, and their risk to be left out. Maybe we have to use different languages, have more community people talking to those communities. We have to be, politicians have to be creative to think what are the elements which are needed in order to come into dialogue and to analyze the needs of those populations and to bring them into the healthcare system, so nobody is left behind. And also, it's maybe practical on administrative level, that administrative blocks are removed from that, saying everybody has access to healthcare independent of his administrative status, whether it's a migrant or not a migrant. So everybody should be taken care of. So I think there is a lot on social policy aspect to think ahead, and it goes as wide as transport, as serving underdeserved communities, how we bring people to into the healthcare systems. I think there's a lot of fundamental thought.
Yeah. No, I absolutely agree with that. It has to be a life course approach. It's just groups. You have women specific diseases and women predominant diseases, which start also at a younger age. So you've got those groups already that are at a higher risk from an early age. So we need to look at a life course approach. And then you've got to obviously, young women with autoimmune disease. Endometriosis is a women-specific problem. It takes 7 to 10 years to diagnose it. These are young women, right? We need to also work on the stigma that it creates, with women's health. So in the UK, for example, they've got these great campaigns going on menstrual issues, right? So they're creating awareness at schools around it. By the way, they've got an amazing women's health strategy. UK, Scotland, Ireland, and Austria, only the 4 countries. Well, I mean, England and Scotland are not a country. I mean, they're part of UK. But there are only these 4 regions where you have women's health strategy that's being actually launched and it's working. Obviously, you need also resources for that and good coordinated action at healthcare professionals at different levels, right? So we need primary care. I think also involving pharmacists in this whole system can be very useful. So it's at different levels, from getting rid of that stigma on women's health issues, to really going all the way across to older women who, as Birgit said, because of the socioeconomic barriers, that they don't get the proper care that they deserve.
Yeah, and it's we heard in a previous episode as well, there are different approaches you need for different communities. Some, don't trust just a regular campaign. Some need to really hear it from their GP. Some need to hear it from a community ambassador. So it's really different how you approach it and how you bring this information to them. So it's quite specific. A fun fact that I wanted to share, I don't know if you know that AI is now being trained to detect heart failure just by listening to your voice. I was reading that. It was quite interesting, actually. So recent studies showed that subtle changes in speech patterns can indicate worsening heart function. It has to do with your lung function as well. So researchers are developing voice-based tools that could help doctors monitor patients remotely or even flag early warning signs before symptoms even appear. It's really interesting to hear how AI can find some solutions to either early detect some symptoms or help us diagnose heart failure early on. And I'm really curious about that as well. What are some exciting innovations that the European Heart Network is seeing in AI and cardiovascular research?
As we know, AI is everywhere now and ever so fast, and every time more faster than we can imagine. And in medicine, it has a lot of potential. So we are, as EHN, through our patient consultant network, engaged in AI research projects funded by the European Commission. And they are threefold. One is really on data, so gathering together the GP's record, registers from the hospitals, but also personal data from the Apple Watch, and condensing it into one, let's say, unified data set which travels with the patient wherever he or she goes, so that the information is standardized and helps the patient throughout the whole pathway, whether it is with the primary care, with the GP, but or whether it's in rehabilitation, whether it's abroad, on a trip, etc., etc.
So to bring all this data together, to collect it,
with a virtual assistant who checks out the unimportant, but takes maybe the very important scribbling of the GP into account. So that is the one.
And that's some research that you're doing around that.
Yeah, it's called IDAVA. You find it on our website. And the second project is called AI for Heart Failure. So using AI to diagnose risk factors which could lead cardiac biomarkers to predict cardiovascular disease, in particular heart failure. Mm-hmm. And the third one is trying to find out about hypertension, and also using AI by looking into finding the elements which is the right therapy on a pharmaceutical level for a hypertension patient, depending on a certain factors, biological factors, again, metabolic factors, which helps then in the prescription. So these are three quite different. And I would add these projects we are involved in, concrete ones, but I think there's a lot of potential also in imaging, looking into diagnosing the imaging, or also for rare cardiac conditions that AI maybe propose to to cardiologist. Well, this could be this a very rare condition among it, and it depends on the cardiologist to then work with AI and say, this is rubbish, but this is this is very good. And it's I think the advantage of AI is also that it's very fast, and this is something where in medicine it's always also very important to early intervene or to early diagnose. And there I think AI can help us.
Has any of these translated in any tools, or is it still in first stages?
It's research. Our patients are advising on it, but I think in imaging, in diagnosis, it's coming quite a lot.
There's some of it is around, So the Mayo Clinic, for example, has pioneered using an ECG to predict heart failure, which can happen 5 years later, or atrial fibrillation, for example, which can be devastating by causing stroke. So this is implemented actually in the clinical practice at the Mayo Clinic and also some hospitals in the US, but also in the UK. For example, they're using that, and there's a combination with the imaging. I'm an imaging specialist, so I've been used to using AI in imaging, which can really help us enormously. So it's the combination of certain cardiometabolic markers, ECGs, imaging. We can get huge amounts of information about a patient. You can really define what's going to happen, predict their future in a very quick way. I think we are not, certainly in Europe, we are not at a level of introducing all those in our regular clinical practice. So there's some way to go, obviously, but the potential is there. And in certain areas, we've made huge progress. The example that I gave you from the Mayo Clinic. Yeah. So we're on track, I think. Just need the resources and the training. I should mention also the training of physicians is really very important.
To be able to implement that or even use that. I'm interested, you mentioned also a biomarker, and I want to know if we know the biomarkers or even gene markers to be able to detect heart failure. Having Armenian roots, I think Armenians, when it comes to high blood pressure, there must be something that can be detected in there. For example, breast cancer, there is a gene marker there. Are we coming close to anything like that when it comes to heart failure?
I believe not yet, because cardiovascular disease has always been a bit backwards and the innovation has been slowed down. But I think the European Commission discovered that a health priority, cardiovascular disease, is a health priority. And so they have started to invest in the cardiovascular health plan as a first in their mandate. So they're writing it busy. And one component is research, because we've been lacking behind in innovation and research in cardiovascular disease a lot. So what has been established for oncology with the cancer plan, we are closer there to using biomarkers into immunotherapy than we are in cardiovascular disease. We are lacking behind, but I think we are. There is the awareness that we need to invest into research of cardiovascular disease, and I think we are getting there. We are getting there, but maybe the results are not yet there as far as in the oncology.
Yeah, and I think that has to be further nuanced in the sense that women's bodies do react differently, so there has to be an aspect to those research things of
protocols.
That there's. Women's health is also then prioritized.
Yeah, absolutely. And clinical trials, what I mentioned earlier, that it's still a factor which needs to be filtered in. We have to call it all the time. All the time. I'm ERA for Health, so they are looking into international clinical trials, And this element, and they say, oh yes, of course we have to do it. But I had to say it, and it had to be recorded in the minutes before it moves on. So it is the repetition. It is the repetition and the constant demand. Otherwise, it will not change because it's not inherent in the system.
Yeah. Mm-hmm. And there is also the Global Cardiovascular Research Funders Forum that launched this a new project call, a research call of 10 million euros.
Yeah.
What are they trying to address? Because that can help us to get closer to some knowledge.
Yeah, so it's a research funders forum. So very interesting. It's heart foundations, the American Heart Foundation, the British Heart Foundation, some of our European members coming together, but also Australia and New Zealand. And they put money out, a grant of 10 million, as you say, and they want to, so their goals are to find risk factors and prevention of cardiovascular disease across all women's life stages.
Okay.
They want to improve clinical diagnosis and the treatment of conditions more prevalent or with worse outcomes among women. So this is also not taken care of. And sex-specific underlying mechanism of cardiovascular disease in women. So where we don't know what are the specific mechanisms. How do female bodies work and how that collides with cardiovascular disease. So there is...
This can have an interesting impact.
It can. I think looking that more than half of the population is women, maybe this just initiative of 10 million is of course not enough. But
exactly. It's a start.
It's a start.
It's also a signal to others. Exactly.
So. Yeah,
I think that's an important signal as well. But so it's an important signal. It's a first step. But I don't know how the political climate in Europe or globally is shaping the momentum for women's heart health or just women's health. How do you see that?
I think there's some positive signs again. So the European Commission has launched a general consultation on women and health. So identifying gender gaps and also looking into the social and health inequalities which exist in diagnosis and treatment. So the awareness is there, and I think that is a very positive signal. It comes together with the Sustainable Development Goals of the UN, saying also a campaign for women's rights. So I think that we are at a good pace yet. Of course, we are so much behind. There's a lot to do, but I think there is an urgency to address it. And maybe it has to do with pandemic, to see the role of women in society, that there is more recognition more and more. There are moves of bringing more women more into politics, into boards, etc. And I think that is also what could help women's health overall to be tackled at.
It's but it's a vicious circle. You know, we talk about gender equity, but how can you start even talking about women in higher positions without having that basic equity in healthcare, without achieving that? But okay, women in higher positions will probably fight a bit more for it. And so in that respect, it can be converted into more of a positive circle, I hope.
To put it on the agenda, to at least
they do, and
put
keep on
light on it.
You have to do that. I grew up in the UK during the time of Maggie Thatcher, when and there's a couple of points that she used to sort of reiterate that are really stuck in my mind, and that is constant but gentle pressure. And women are expected to provide gentle pressure, not the hard hit the agenda. And also, Tina, there is no alternative, right? We have to move on. We have to carry on. So.
Are there interesting policies? I've heard also some examples from the UK, but are there interesting policies in Europe that could be replicated, that are working?
I think there are a few, but they are too small. I think the what our members do, European Heart Network, at local level and regional level, they reach out, they talk to people, they get involved with the communities. I think that is an approach that works, but it needs to be combined also with a plan, with resources, finances, from a European level. So I think both levels have to work together. So if at national level it works, we need to indicate that to the European policy level and demand that means are put into the way, like the European Cardiovascular Health Plan, a structure, funding, policy at research level, at patient level, at prevention level, so that all these building blocks come together to make a change. And I think it's both. At local level, there are already things that work, but we need to communicate that to the EU level. And from the EU level, we need the political and financial support to go back to the national level.
It has to be really a coordinated action, and that the EU has really a strategic plan.
Yeah.
And make really agreements with all the EU members.
Yeah. And it worked already. We saw it in COVID when there was procurement measures. It works because health doesn't stop at the border. So you can have better deals. You can have better cooperation, better use of resources, a sharing of experts, knowledge centers. I mean, there is a lot of potential which is not used yet.
Yeah. You know, COVID, that was an urgency, right?
Yeah, exactly.
So we need to create that similar sort of urgency for women's health because, you know, it's really, we're in the 21st century and we are still lagging so far behind. That is, hence the word outrageous.
Yeah. But at the same time, COVID make, from what I've learned from you as well, you know, what we saw 2 years later, the results of COVID when it came to your heart health, you know, it increased when it came to cardiovascular diseases because it wasn't seen as, you know, urgent to just get heart screening. That wasn't really high on the agenda at the time.
No.
Yeah.
No. People were also afraid, I mean, to leave the house, you know, to get to the consultant.
Yeah. Not just screening, but also people who were actually also suffering didn't get to the get to their physicians, so their conditions got worse, or they even died.
What's one thing you wish every woman knew about their heart health?
That it's very central. The heart is a very central organ, and it is also connected with everything else. I mean, it's connected with all the other organs, and if the heart fails, everything stops. I mean, it's
You know, I talk, and I keep on hammering this point. It should be a life course approach for women because many of the conditions that women experience during their life course actually culminate into cardiovascular disease, causing it, making it the number one killer, right? And so it is really important to get rid of that preconceived idea in society, men and women, that heart disease isn't just a man's problem.
Yeah.
That it can affect both men and women, that it is a killer, important killer, the number one killer of men and women, and that the risk factors are the same, but those risk factors affect women differently. Right? And so those are the awareness, those are the important points, I think, that women should be made aware of.
We've talked about the implementation aspect of it, why it's outrageous, and to wrap up this conversation, I would also love to end the way we began with one word, but to leave something for our listeners. You know, it's something to hold on to, a word that captures what women's health means to you, or the shift you believe we need. What would that be? What's one word they could take away from this conversation?
I'm going to use 3 words, actually, if I may.
One.
No, I think we need to do more, we need to do better, and we need to do it now.
The urgency of it.
Yeah.
Thank you very much for that. Birgit, so what's one word you would like to leave our listeners with?
For me, it would be courage, because the heart is so, you need to take heart. So you need to be courageous to implement change, to create awareness, to make a difference to women's heart health. I would choose courage.
Courage.
Yeah.
Courage and the urgency of things are quite important. Thank you very much for the insights that you've shared here today. It was really lovely to learn so much about heart health from both of you, but also thank you for doing the work that you're doing, which is also quite important. I hope you enjoyed it as much as I did.
You certainly did.
Yeah.
And I hope our listeners did as well, but I'm sure they did. And there is so much still to learn about women's health that we will try to uncover in the next episodes as well. Thank you.
Thank you very much. Every success.
Thank you.